I'm very grateful to be here. Thank you so much I know it's been a long day. Everybody yawn, stretch, take a second to increase your energy a little bit here. I'd like to start out by telling you just very, very briefly what brought me to cannabis. And it was chronic pain. I was a patient initially myself. I had had bacterial spinal meningitis that left me on 26 pharmaceuticals in a wheelchair on fentanyl patch, Neurontin, many other horrible medications. Now I'm on 3 in cannabis. I will tell you right now that I'm a huge proponent of pharmaceuticals when they're used correctly, but I think that our doctors and our medical community can do a lot better job of figuring out ways to treat people using integrative medicine and not just going to their PDR to pick the next drug and adding one on top of another. So I think I'm a testament to the fact that I'm standing here instead of rolling up the aisle and able to talk to you coherently and not be drooling and nodding like I was on the opioids. So thank God for cannabis. In addition, I'm very, very excited about the work that Cortigen's doing in particular because I come from a family of, you're pretty well, by the time you're 60, you'll have been diagnosed with one form of a cancer or another. And they're still using the same types of treatment protocols they were using in the 70s, the 80s, the 90s, the aughts, et cetera. And there's got to be other ways, or at least ways to bring cannabis in with some of the results we're seeing. I know that the conference topic is primarily looking at neurological disorders, but if you'll humor me, I'm going to talk just a little bit about cancer here because I think that it's something that's not nearly addressed enough. And I've just in having some casual conversations here with some attendees, some doctors, they said, you mean you use cannabis for the side effects of palliative? And I said, well, that too, depending on the objective of the patient, but we also use it to kill cancer. So the question I'll be addressing is, can cannabis be consistently and accurately dosed? And the answer is hopefully clear from the show. Okay, so the first thing I want to talk about is the fact that we do, in fact, promote whole plant extracts and not isolates. Isolates do, in fact, have a role for standardization of medicines. If you have whole plant, and let's say you're trying to standardize something to 60 milligrams per mil, and it's coming out your whole plant extract somewhere at 55, 57, 58, there's nothing wrong with using an isolate to help to standardize, to bump up the numbers, but you have to have the entourage effect. You have to have the synergy between the terpenes, the flavonoids, everything else that's in the plant, in addition to the cannabinoids that are in there. And even the cannabinoids working together have a synergistic effect. We know that myrcene, which is an old hippie trick of eating mango before you got high and it got you higher, and now we know, of course, the reason for that is that myrcene helps to increase the bioavailability and break through the blood-brain barrier. Limonene, something that's in limes, gives a much more uplifting experience. We know enough about the terpenes now to know which ones work best with certain people and certain diseases. But the one that I think a recurring theme that you've heard here today over and over again is that there is no one size fits all. One terpene might make me very sleepy and it might make somebody else very, very activated. So you have to work very closely in communication with your patients to find out immediately getting feedback with what works for them. Now, the entourage effect is, if they've identified, sometimes I hear 200 different terpenes, 100 different cannabinoids. Sometimes I've seen reports that said 400 terpenes. I don't know the answer to it. I'm not a scientist. I'm actually an engineer. So I come to this from a background of data and wanting to see patterns and wanting to see what's working and what's not working and take track, looking and analyzing these things and looking for the patterns. But I can tell you that with all these various combinations, I tried to run the formula last night of how many various combinations, if you just had 2 compounds present in any plant and you took the hundreds of cannabinoid potentials and the hundreds of terpene potentials and you added them together and you figured out which plant had it, it's a pharmacy in a plant. I mean, every different combination will give you a different effect, slightly variance depending on who's taking it and how it's going to impact them, of course. But it is, in fact, I tell people, have an infused CBD in your medicine cabinet, have a jar of flowers, and then have an extract, and you've got pretty well a whole medicine cabinet, a whole pharmacy in your bathroom. Now, This is a slide that I borrowed, with her permission, from Dr. Cristina Sanchez at Complutense University, where she talks about the mutation of the cancer cells, like what actually is happening when it goes through the process of, some, not all, but most cancer cells go through the angiogenesis process, and then they go through and they go on and they metastasize and they spread and go on to other parts of the body. And then, of course, that goes into the staging of the cancers. But the traditional treatments are designed, traditional chemotherapy treatments are designed to work on proliferating cells, because your cancer cells are rapidly proliferating cells within your body. Most of your cells are not proliferating. Most of your cells are pretty well stagnant. I'm not a scientist, I'm not a doctor, I can't explain more than that, but I know that that's the understanding. As a result, your hair falls out because your hair is continuously growing, you're nauseous, you're vomiting because your stomach is, your digestive system is a constantly active thing. So cannabis is found to work very, very effectively against the things that we have here, like hair loss, anemia, constipation, diarrhea, pain. Joint pain and bone pain is a very, very big problem with people that are going through chemotherapies. The toxicity levels the cannabis can help quite a bit with, and the lack of appetite. In addition, lo and behold, it also works on the tumor progression. Cannabis has been shown to be very much significant in apoptosis. Now, the cannabinoids, or the CB1 or the CB2 receptors, are activated by the cannabinoids, and it begins the chemical cascade that results in apoptosis. Everything in between the top, where I don't know where my clicker. Everything that goes between here and here is up to much smarter people than me in the room to explain to you. I just know it does. Now, I asked Cristina, I said, Dr. Sanchez, I said, could you please explain to me what is the difference between necrosis and apoptosis? Because they both end up with dead cells. And she said the difference is that necrosis is like a car wreck. It causes a lot of damage. The cells cause damage to the surrounding other cells and the tissues around it, which results in inflammation, which results obviously in a negative prognosis, which is why they have to be very careful at the speed at which they kill cancer cells with chemotherapy, so that you don't have too much necrosis going on and causing too much other disease that'll end up developing in the body. Where apoptosis is cell suicide, which is very intimate experience. The cell basically collapses within itself, and that's a layman's description, and dies, leaving behind and being captured by the other healthy cells, so that it doesn't leave behind any residue which causes any disease and problem within the body. The second thing and then also the ID1 gene is something that Dr. Sean McAllister has done work on, looking at which cancers that have ID1 involvement. ID1 especially is a problem. I was speaking to one of the parents last night, because of the ID1, which is something you see in infants, newborns and fetuses and children. It's something that's, when you have a lot of growth going on, the ID1 is very involved. Unfortunately, it's also present in quite a few different cancers. The good news on that is that CBD is seen to downregulate the expression of the ID1 gene, and the ID1 is what causes, when it's present, you're going to have a lot more proliferation and metastasis of the cancer cells. So when we look for certain cancers, we can go, okay, let's start out at least like with a prostate cancer or breast cancer or something else and say, okay, if we know that it's a non-small cell lung, for example, we might start out with a much higher level of CBD and lower in THC than we would in one. For example, the majority of glioblastomas, multiform, the GBMs that we've looked at, have not had ID1 because they've not responded as well to the CBD. Sometimes they do. And so that's where the experimentation and the not being one size fits all comes into play. The second thing I'm going to talk to you about today is chronic nerve pain. And THC has been shown it has 5 mechanisms involved with pain reduction, the CB1 and CB2 activation. I can read this to you if you'd like me to. Retards chemical reaction at peripheral pain receptors, and I have had this explained to me multiple times, interrupts pain signal at the dorsal root ganglion, interrupts pain signal at the neuron, activation of CB2 at leukocytes triggers anti-inflammatory response, much like a steroid would do, and the psychoactive euphoric effects and short-term memory reduction mitigate stress response to pain. Now, why this is really important is the same way as Dr. Meshulam says that we don't want to walk into a grocery store and remember 500 people's faces that we see there. We also have the gift of forgetting. It's almost like having a break or having a freedom from the suffering that we have. It just gives us a break from it. Anybody who knows anyone with PTSD and they have this recurring fight or flight response that's going on, they have the ability to have a break in that and have the calm and get out of that fight or flight, and it's the gift of the forgetting that goes on. The CBD in this case works anti-inflammatory mechanism, which works very much like a hydrocortisone, but with much, much higher success rates in many, many cases. I'll tell you myself personally, I have pretty severe asthma, and about once or twice a year I would have to go on a steroid as a result of every time I got on an airplane I got an upper respiratory infection. You know, it always attacks the weakest part of the body, and I would have to go on to steroids, and then it would take me months and months to get off of them with extreme bone pain and all sorts of side effects. I have not been on a steroid now for over 3.5 years because of cannabis. So. All right, here's just a visual representation of the nerve. Okay, so I want to show you how we do it. So we started collecting data on patients back in end of 2010, beginning of 2011, saying, okay, nobody can tell you how to dose. Nobody can tell you what's in the medicine. Nobody can tell you how this works. I mean, we went around to some of the best places and the best people, and at the time there was like, you know, they were beginning the testing labs, and they were still using gas chromatograph to do cannabinoids, which of course we all know it actually decarboxylates in the process of testing it, so it's not an accurate test if you're really trying to know what milligrams you're taking. You'd go to a dispensary and it would have a Rice Krispie bar and a piece of cellophane that somebody stuck a piece of masking tape on it and wrote 1 to 20 doses, whatever that meant. There was no labeling, there was no understanding, so we said we can do better than this. There's got to be a better way. That's when the engineer and me, the process came in to collecting the data. We started collecting about 300 different data points with patients and looking for patterns and what was working for various diseases and seeing if we could find a way to be able to predict moving forward with somebody else based upon various different variables what was going to work for which diseases. One of the interesting things that we found was that there's 5 questions that if we get those 5 questions answered, we can do, I mean, obviously the confidence level in our results is going to be slightly lower than it would be if we asked 300 data points, but we found that if we find a person's age, because there's I think you may have picked up on a pattern of this today, there's definitely a correlation between age and dose. The younger the patient, the higher the dose. The older the patient, the lower the dose. At least that's the patterns that we've been seeing. So one of the most important things that we look at is the age. Then we look at the diagnosis, of course, and if it's a cancer, whatever it is, we look at staging and everything else and other treatments that they're having. We look at all the pharmaceuticals and supplements with the medications that they're on. We also then look at their previous experience with cannabis or cannabinoid therapies, and then we look at what their objective is. Because somebody might come to me and say, you know, I've got breast cancer and blah, blah, blah. And so I'm immediately thinking, okay, we're going to put them on this, we're going to put them on that, da, 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 we're going to start killing the cancer. They just want to not be nauseous. And then, you know what, that's their right. It's not up to me to tell them what their goal should be with their treatment. That's a discussion between them and their doctor. And frankly, we want to put this back into the hands of the doctor. So we've been developing a software all these years. It's CDR Med. It's now in alpha. It's moving into beta. In fact, I think the site just went up again last night to be moving into beta to help to make it a conversation that a physician can be having now with his patients instead of having to have somebody like me doing it. I'm not qualified. So the first patient I'm going to look at here was a 43-year-old female that came to us with breast cancer, stage 4. And her goal was killing cancer cells. That was absolutely, she wanted to live, and she was going to do whatever it took to live. So the first recommendation that we made to her, now this was a while ago, was 150 milligrams of THC and 75 milligrams of CBD. Now, when I say that this is our first, people want to know where they're going in their treatment. They may not ever get there, or they may have to go way past it. But this is a starting out goal. We can make adjustments. We start people out on 1/3 of a milligram. We've standardized our infused oils at 10 milligrams per milliliter, and it's between 28 and 30 drops per mil, which means that each drop is 1/3 of a milligram. And that way, if we can start somebody out, and we can tell very, very quickly how high we're going to have to go before we start having a therapeutic effect. Of course, our extracts are much, much higher, and we're getting ready to move them into standardized as well. I believe 30, 60, and I'm not sure if there's another one in there or not, milligrams per mil of major cannabinoid. So this was the first one. The doctor recommended 150 milligrams taken in 2 doses, and then the CBD. We also recommend that people separate out their major cannabinoids and not take them together when they're doing cancer treatments. CBD is an antagonist, and THC is an agonist. So we want the agonist in there doing its job and being effective. And a couple hours later, you introduce the CBD. There's still synergy going on in the body, but in the meantime, we know that all the CB1s have been activated that need to be. We also want there to be beta-caryophyllene whenever possible, so that we have the CB2 activation as well. So this was how we were able to do it. So how do we turn that recommendation from a doctor or from a clinician into results based upon what's available right now with the state of products? So the first thing we looked at was lab results. This one happened to be one that was done at Steep Hill Hayland a long time ago. It doesn't matter. The point is, if you have a good testing lab, a good reliable testing lab, and that's kind of an oxymoron, unfortunately, at this point right now, because there needs to be a lot more standardization and regulation. We recommend that people have their medicines tested multiple times at multiple locations to find out what really is closest to accurate. Anyway, in this particular one, the THC had 650 milligrams per gram of extract, and the ACDC, which was the high CBD, had 580. So we were able to then give them, from the sour kush keef, which you see here on this strain on the left and on the right, we were able to then make a recommendation to the patient to take this, instructions on how to actually take this medicine correctly in order to achieve the exact 150 milligrams that was being recommended by the doctor. Okay. The second thing we were able to do, we were able to repeat it again and again and again. Then the person was in remission. We were able to move to a maintenance dose of 100 milligrams of CBD at this point and only 50 milligrams. And what we do, I heard the question asked to the panel earlier, that we said that if after a person goes through 2 full cycles of showing NED, then we will then reduce them to between 10 and 12% of whatever their highest. That's the goal, to go on for a maintenance dose. It looks like I talked too much at the beginning, so I'm not going to be having a chance to show you, but this is how we then were able to achieve the maintenance dose for this patient. And then this is just showing the patients what they took throughout the whole treatment protocol, and how they were able to consistently take the medicine through this. On the chronic nerve pain, I just take 1 minute very quickly to show you. We had to go through a lot of experimentation with this particular patient. We did it with the the THC first, 25 milligrams. Very, very quickly, the patient just zoomed right past that to 100. And that still wasn't enough, so we then introduced THCA into the picture, the THCA, because I'd rather wanted to have that because they were having some stomach issues, and we were able to dose that accurately with these medicines, fulfilling the doctor's recommendation. Then we brought in then cannabidiol. It turned out that 80 milligrams of THC and 60 milligrams of CBD was the magic ticket for this particular patient, and we were able to do it over and over again, repeating that to keep them the same one. If you'd like for more information, you can go to cdrmed.org and ask for beta access. I think I've covered pretty much all these things. We must have clinical trials. It doesn't need to be in the hands of people like me. I'm glad that my software is going to be able to put it into the hands for the clinical trials and the doctors and all, but I'm very, very happy to be here, and I'm very excited about the work that I heard today. Thank you. The patients, the chronic pain patient that's their maintenance dose, and they're doing their life. They're going to work. They're having a lovely life. And the breast cancer patient is still in remission and doing fantastic. Yes. Mm-hmm.
Thank you, Mara.